Maybe let's just get started and then people can just file in if they,
Okay.
I think
So,
there's a couple things, but that's okay.
okay. So we'll first start with the fatty tumors. So the whole thing about the soft tissue tumors is the things that we'll be talking today are relevant for your slide purposes. There is a whole list of other esoteric stuff and genetic stuff, which again, after the class, I can share this. I'm going to be sharing this Word document with you. You guys need to go through this. So the things that are highlighted in red are the ones that are going to be, you need to know the histology of those lesions. The things which are highlighted in blue are like the questions that it can ask you in terms of genetic mutations. You should know about them because they're generally going to be the wrong answers when they are putting them in the multiple choice questions. There is a list of these zebra tumors, which is almost always not the correct answer, but you should know specific genetic aberrations associated with these tumors. The world of soft tissue pathology in the last couple of years has really evolved in terms of a whole bunch of next generation sequencing determining a whole variety of range of tumors, which is which for me to go through that is beyond the scope of this class. It's very soft tissue specific. So this is a very comprehensive list of all that has been, has come about in the literature in the last few years. So this is again something which, I would encourage you to read. This is again, if you are able to grasp this kind of stuff, you're clearly like almost in the 100th percentile of what you're expected to know of soft tissue. The focus of the class today is to basically make you aware of the red entities, which are the histology, which is the histology of the tumors which you need to know about. Okay, so coming first to the fatty tumors. So in fatty tumors, pretty much lipoma is a very common benign fatty tumor. They're not going to ask you a classic lipoma. So what are the lesions in fatty tumors that they like to ask you? So first, let's talk about nevus lipomatosis superficialis. This is it's the other it looks like a cutaneous polyp or also known as a fibrolipoma. So what it does is it's very difficult to differentiate it from a cutaneous polyp or a fibrolipoma versus a nevus lipomatosis superficialis unless you have the clinical. They both histologically look the same, and what you have is a whole amount of fat which has replaced the dermis. So when you see the fat in the dermis, that's nevus lipomatosis superficialis or a fibrolipoma. That's pretty simple. The One of the important tumors is an angiolipoma. That's a variant of a lipoma which has a nice associated vascular component with it. These can often be painful lesions. There are specific criteria. Just because you have increased vessels in a fatty tumor, you don't call it an angiolipoma. The concentration of the capillary-sized vessels is at the periphery of the lesion. So you can see this nice vascular proliferation and mixed with fat. It's often at the periphery of the lesion. These are capillary-sized vessels. They can often have microthrombi inside the vessels. So that is an angiolipoma. So it's again an important board question. Now let's come to a spectrum of tumors which are benign fatty tumors, which all share some kind of a similar genetic aberration, which is monosomy or partial loss of chromosome 13 and 16. Hence, they all occur in a spectrum, and included in this category are three tumors, which are spindle cell lipoma, pleomorphic lipoma, and a myxoid lipoma. So, at any given point of time, the fatty tumor can have varying proportions. So, they can have spindle cells, they can have myxoid change, and they can have pleomorphic cells within them. So, it's spindle cell, myxoid, or pleomorphic lipoma, which is in a spectrum of lesions, all sharing monosomy or partial loss of chromosome 13 and 16. The spindle cell lipoma, which is the most common among them, the classic location is the upper back, shoulder region, scapular region of, a middle-aged male or a female. And what you see in here is a fatty tumor which has got these expanded fibrous septae. When you go in the fibrous septae, you see these kind of shredded pieces of collagen, also called the shredded carrot appearance, along with this increased cellularity of the spindle cells. So these spindle cells, they are pretty monomorphous with no pleomorphism. You can see they have very banal, slightly elongated nuclei. And an important component is the presence of mast cells. So often in the stroma, you will see mast cells. Now, when you see, if you just take this high power into view, along with these spindle cells and the mast cells, neurofibroma comes in the differential. So one of the closest differential of a spindle cell lipoma is a neurofibroma. Now, also, when you see proliferation of spindle cells along with the fat, you also think about a DFSP, right? So now it's important for you to just make a note of this particular fact that spindle cell lipoma, neurofibroma, and a myxoid variant of DFSP, which is not very cellular, can kind of look similar, okay? DFSP will never have any mast cells. So DFSP does not have any mast cells. All these three entities, spindle cell lipoma, pleomorphic lipoma, spindle cell lipoma, neurofibroma, and DFSP can be positive for CD34. Okay, so this is something that you need to remember. So CD34 positivity is not only seen in DFSP, you can see them in the spindle cells of neurofibroma as well as a spindle cell lipoma. Okay, so these are some of the second order questions that you're supposed to be aware about. Mast cells are seen in the stroma of a spindle cell lipoma and a neurofibroma, but not in a DFSP. But the CD34 positivity can be seen in spindle cell lipoma, neurofibroma, and a DFSP. Now, spindle cell lipoma, however, you have to look at the whole architecture of the lesion. You have the fat, you have the expanded fibrous septae with the shredded collagen pieces, shredded cavity appearance, along with the presence of mast cells. These spindle cells will be S100 and SOX10 negative, which will also be negative in a DFSP, but it will be positive in a neurofibroma. So this is a nice example of a spindle cell lipoma. I'm going to show you some more examples. This is another example of a spindle cell lipoma. So you have a nice fatty lesion. You have all these increased areas of fibrosis. When you go within the lesion, you can again see the proliferation of the same looking spindle cells with these shredded pieces of collagen, the shredded cavity appearance. There are scattered mast cells within the lesion. So this is a nice example of a spindle cell lipoma. Okay, now let's come to the next category, which is your myxoid lipoma. So a myxoid lipoma has predominant myxoid stroma within the lesion. Often a myxoid lipoma occurs along with some degree of spindle cell lipoma. So you can see that this is a nice circumscribed fatty tumor. You can see the fat within the lesion. There is lots of myxoid change, but you also see these kind of fibrous areas with this proliferation of these spindle cells within the lesion. So it's in a spectrum, as I said. So if you just saw the myxoid change, yes, myxoid lipoma. You're also seeing some scattered mast cells within the lesion. So this is a spindle cell / a myxoid lipoma. Now, they're not going to ask you to differentiate how many types of lipoma are within the tumor. If you see a myxoid lipoma, that's what you will call it. But what I'm trying to emphasize the fact that these tumors occur in a spectrum. It's not uncommon to see components of more of one of these lesions within the same tumor. So this is a nice example of a myxoid lipoma. Now, one of the things that is an important marker which you guys should know about, which has again come about recently, is this marker known as RB1. And this is again going to be there in my handout. So RB1. So the RB1 loss is basically going to be seen in, the reason we want to do this is because, say, suppose you see a myxoid lipoma or a spindle cell lipoma, and you want to differentiate it from a well-differentiated liposarc. This loss of RB1 is basically utilized. So I'll show you the immunostain, and this loss of RB1 is seen in these bunch of tumors. So you can see that the spindle cell and pleomorphic lipomas will show loss of RB1. But however, this is going to be retained. You see that RB1 expression is retained in well-differentiated liposarcoma. So this is a marker which is now increasingly used in complicated cases of pleomorphic / spindle cell lipoma, trying to differentiate them from a well-differentiated liposarcoma. So you should know about this. The loss of nuclear expression of RB1 is going to be seen in a spindle cell / myxoid / pleomorphic lipoma. So I'm going to show you an example of that. So let's see this. So this is a nice case. So this is the RB1 marker, and you can see that it's a nuclear marker. So you can see that it is staining the cytoplasm, but it is not staining the nuclei of these cells, which means that this is a benign lipomatous tumor. So that's a loss of nuclear expression. You wouldn't see that. The nuclear expression would be retained in a well-differentiated liposarcoma. Okay. The next thing we're going to talk about is I've already talked about CD34. So the importance of CD34 immunostaining in a DFSP, spindle cell lipoma, and neurofibroma should also be known because that can be asked as a second order question. This is another example of a myxoid lipoma. So you can see the nice fatty tumor with lots of myxoid stroma within it. So it's pretty easy to make the diagnosis of a myxoid lipoma. Now let's come to your pleomorphic lipoma with floret cells. So that is probably one of the most challenging one that you would encounter. It's a fatty lesion, as you can see in here, with some degree of fibrosis. But what strikes you at low power is that it looks a little irritating to the eye. The reason it looks irritating to the eye is because you see all these pleomorphic cells. What does pleomorphism mean? Pleomorphism means that the cells in the field that you are looking at, they are varying from each other in size and shape. So cells don't look similar to one another. When there is absence of monotony within the tumor, those cells will strike out. Pleomorphism generally in a soft tissue tumor is considered to be good. Okay, it not always, but it is not always indicative of a malignancy. That's what I'm trying to say. So, like for example, in this fatty tumor, there isn't much cellularity, but there is pleomorphism. So you can see that there are some large nuclei which are standing out. In the absence of cellularity, pleomorphism will probably not be that bad. Just pleomorphism alone is not bad. And when you go up on high power, you see that many of these cells, why are they pleomorphic? Is because they are multinucleated. So pleomorphism because of multinucleation is largely indicative of a degenerative phenomenon in soft tissue pathology, and hence largely is considered to be benign. So you can see that these are pleomorphic, multinucleated floret cells. They are kind of angulated. This is a beautiful example of the floret cells, which you see in a pleomorphic lipoma. So again, not a whole degree of cellularity, pleomorphism composed of these multinucleated floret cells. So that's a pleomorphic lipoma. If you were again to stain this with RB1, there will be loss of nuclear expression of RB1 if you're trying to differentiate it from a well-differentiated liposarcoma. Let me show you some more examples. This is another example. Now, another thing about fatty tumors is that spindle cell lipoma, and especially pleomorphic and spindle cell lipoma, is that the fat may not be a very predominant part of the lesion. So there may be only a scant amount of fat within the lesion. Hopefully, they are not going to show you such complicated cases, but that can happen. Okay, so here you see that there is the fat within the lesion. There is proliferation of spindle cells, but you clearly see the pleomorphism. You see that they are scattered in large atypical cells. And when you go up on high power, they are multinucleated. So this is a beautiful example of a floret, multinucleated floret cell in a pleomorphic lipoma. Now, obviously the closest differential diagnosis of a pleomorphic and a spindle cell lipoma would be a well-differentiated liposarcoma. So I'm going to show you an example of this, but remember, most often when they are putting well-differentiated liposarc or atypical lipomatous tumor in the differential diagnosis, they are, it is essentially going to be a misleading differential diagnosis. So atypical lipomatous tumor or a well-differentiated liposarcoma is going to be a misleading diagnosis. It is not, they're often putting it out. First of all, remember that the terms atypical lipomatous tumor and well-differentiated liposarcoma is the same entity. You use the term well-differentiated liposarcoma more often in internal organs. So the most common site of a liposarcoma is the retroperitoneal region. When the well-differentiated liposarcomas occur in accessible sites, such as the forearm or on the legs, they are easily excisable. Hence, the well-differentiated liposarcoma terminology is not used. We prefer to use the term atypical lipomatous tumor. So well-differentiated liposarcoma and atypical lipomatous tumor are synonymous terms. They're extremely rare soft tissue cutaneous tumors. Okay, these are deep-seated tumors, so they occur beneath the fascia, and hence they are often misleading. So the soft tissue tumors which are malignant, which are pertinent to dermatopathologists, are DFSP, are going to be your epithelioid sarcoma, are going to be leiomyosarcoma, are going to be pleomorphic dermal sarcoma and AFX, which occur within the skin. When they are deep in the skin, deep in the beneath the fascia, they're subfasciate in location, they are basically not going to be easily accessible, right? So that is why these are more of soft tissue expert kind of questions. They're most often put in there to differentiate it, to basically mislead you guys in the terms of differential diagnosis. So that is an important fact to understand. Now, this is a beautiful example of a well-differentiated liposarcoma. So you see that this is the fatty tumor, and it is separated by these uneven areas of increased cellularity and fibrosis. So it is too big for a spindle cell lipoma. When you go up on high power, you clearly see that there is much more increased cellularity within the lesion. And what you're again looking for is some pleomorphism. The classic finding is the presence of a lipoblast. A lipoblast is going to be a malignant fatty cell which has got an abnormal nucleus. So something like this. So this is a lipoblast. So this is the nucleus of a fatty cell. And this is again much beyond the scope of you guys to understand at this point. What I'm showing you an example, and clearly you can see its differentiation from the spindle cell lipoma. It is much more pleomorphic, much more large. There is greater degree of cytologic atypia. And then the important thing you need to know about well-differentiated liposarcoma, which may be asked, is again going to be in your basically in your handouts, which is going to be from a cytogenetic point of view. These lesions, they show ring chromosomes, okay, and MD-M2 amplification on chromosome 12q15. So that can basically be asked. So you need to know about this. I'm also going to show you an example of a myxoid liposarcoma so that you can see its difference from a myxoid lipoma. But you need to know this about myxoid liposarcoma. These are most common tumors which are seen in younger individuals. The extremities, especially the lower extremities, the thigh is a common site. And this is the classic, basically the translocation that is found within the lesion. So this needs to be memorized. So let me show you an example of myxoid liposarcoma, and you can see the difference. So you can see these pieces of extreme myxoid fatty tumor that has come out. And you can see that again, the classic finding of this lesion is it is not even there so much of fat. It's a delicate crow feet branching vascularity of the lesion. It's very vascular. You see all these are tiny shaped capillary sized vessels within the lesion with a lot of hemorrhage inside the lesion. And there is not much of pleomorphism. There is not much amount of fat within the lesion. What fat is there is the primitive fat. So you can see how there is marked increase in cellularity. So you can see the difference between the myxoid lipoma. Myxoid lipoma is not that vascular. It doesn't have this delicate branching network of capillary sized vessels. So this is an example of a myxoid liposarcoma, and it shows the classic genetic translocation that I basically mentioned. And again, this as a board question, this is very classic. Like if you see it once, you will remember that this is a myxoid liposarcoma. But again, most often, if it is in there, it is going to be a distractor, unless and until they're asking you a specific question, which will be pertinent to the genetic translocation within the lesion. So the soft tissue tumors, which in terms of histology, you should absolutely know about, is an angiolipoma, a spindle cell, pleomorphic, and a myxoid lipoma. The other things like a well-differentiated liposarc and myxoid liposarcoma are generally going to be distractors, but you should know some second-order questions associated with them. In association with immunohistochemical staining, learn about CD34, as well as the loss of nuclear expression of RB1, which is seen in benign fatty tumors. And that all benign fatty tumors, they show a spectrum of monosomy and partial losses of chromosome 13 and 16. Okay, let's come to your next category of tumor, which is going to be your fibrohistiocytic tumor. This is by far the largest category of the soft tissue tumors and some of the most frequently encountered soft tissue tumors. So let's first start with the spectrum of scar and keloid. So the first one is a hypertrophic scar. The hypertrophic scar is not really a tumor, but we will start with this. So first of all, about the morphology of the fibrohistiocytic cells. So notice that the fibrohistiocytic cells, they basically have non-discrete nuclei and indistinct cytoplasmic borders. They have lots of pink cytoplasm, but the nuclei are very non-discrete. They're kind of like elongated, but not really thin and tapering, like what you see in neural tumors, and not really the cigar shaped with the pointed edge as what you see in a smooth muscle tumor. So we will talk about neural and smooth muscle tumors, and you will see that their nuclei are much more well defined. These are non-discrete nuclei with indistinct cytoplasmic borders. So when you see nuclei like this, that makes you think about a fibrohistiocytic morphology. Now, hypertrophic scar. The first thing is you will see effacement of the rete-rich pattern, and there is haphazard proliferation of these fibrohistiocytic spindle cells. The nuclei, you can see they're often arranged in one field. So they are, in this case, they're going in an east-west direction, or they can go in a north-south direction. And what they are laying down is collagen within the lesion. So they are going to be sheets of collagen within the proliferation of these fibrohistiocytic spindle cells, which are all kind of arranged in one field going parallel to the epidermis in this particular case. So effacement of the rete-rich pattern, proliferation of fibrohistiocytic cells with non-discrete nuclei, and presence of the dense collagen laid down in between them. So this is all indicative of a trauma. When the nuclei are proliferating in one east-west or north-south direction, most common they are laid parallel to the epidermis is what you can see here. There is a spatter of variable inflammation within the background of the lesion. There is some cellularity with the increased vessels, but, it's not a whole lot. So those are all the features of a hypertrophic scar. So I'm going to show you some more examples. The closest differential diagnosis that you get confused with the hypertrophic scar is a leiomyoma. So we will talk about that later. So in a leiomyoma, again, the cytology of the nucleus and the placement of the nuclei is very important. So as you can see why do you confuse it with the leiomyoma is because both of these look very pink. A leiomyoma is very pink and a scar is also very pink. But the pinkness in a leiomyoma is because the individual cells, they contain a lot of cytoplasm, and we'll see that later. But in a scar, the pinkness of the tumor is because there is lots of collagen in the lesion. So you can see that all these nuclei, which are again proliferating in one direction, have laid down lots of collagen in the background of the lesion. So that is a hypertrophic scar. You again see that there is a sharp demarcation from the adjacent dermis, which could be seen in any soft tissue tumor. But again, you see the parallel arrangement, the east-west proliferation of these fibrous histiocytic cells, and how the collagen is laid within the lesion. Here, it's going in a north-south direction. So east-west and a north-south direction. So they're often grouped together like this, not really forming fascicles, but haphazardly arranged and then laying down the collagen in between them. So this is a hypertrophic scar. One step beyond it is going to be keloid. The keloid is going to show you dense hyalinized collagen bundles within the lesion. So you can see the keloid. This is densely hyalinized collagen bundles within the lesion. When you see this, that is diagnostic of a keloid. So the background, it looks like a hypertrophic scar. You can again see the non-discrete proliferation of the fibrohistiocytic spindle cells. It's laying down the collagen. And then you start seeing these areas of bright pink eosinophilic hyalinized fibrotic collagen bundles. And that is diagnostic of a keloid. Okay, let's go to our next entity, which is the most common tumor that we encounter, which is a dermatofibroma. So a dermatofibroma is the most common benign soft tissue tumor and the most common benign fibrohistiocytic tumor that we encounter. It has a varying morphology. This by far is the most common morphology, wherein the overlying epidermis shows a little induction. So you can see a little epidermal hyperplasia overlying the lesion, and you see the proliferation of the fibrohistiocytic spindle cells. So there is increased cellularity within the dermis. It almost looks like the edges of the lesion are contracted because the collagen is being pushed in. That's called collagen trapping. So the periphery of the lesion, it's not very well circumscribed. It is circumscribed, but not absolutely well circumscribed, and definitely it's not encapsulated. But you can see that there is trapping of the collagen bundles at the periphery of the lesion, and within the lesion itself is proliferation of these fibrohistiocytic spindle cells. The higher you go on a dermatofibroma, the more confused you will become. The best diagnosis is made at low power. So increased cellularity with collagen trapping within the lesion. Dermatofibromas can be very inflamed. So the more inflamed they are, the more hemorrhage they are, the more likely they are going to be benign. So keep that in mind. So I'm going to show you different kinds of dermatofibroma. So that was a classic DF. This again, you can see the nice induction on top of the lesion. This is a dermatofibroma which has lots of hemorrhage, as you can notice over here. The more the hemorrhage, the better it is. You can see the collagen trapping within the lesion. You can see again the proliferation of the fibrohistiocytic spindle cells. Again, I would refrain from going too much on high power. It's more of a low power diagnosis. When there is hemorrhage, there is going to be hemosiderin. So you can see the hemosiderin pigment within the lesion. You can have pleomorphic spindle cells, multinucleated giant cells, xanthomatized histiocytes within the lesion. Whole bunch can occur. So let's see some more examples. This is again another example of dermatofibroma. With hemorrhage, you can see the nice induction on top of the lesion. There is fibrohistiocytic proliferation of spindle cells within the lesion. You can see lots of hemorrhage and hemosiderin deposition within the lesion, the hemorrhage and hemosiderin deposition, the nice collagen trapping at the periphery of the lesion, as you can see in over here. There is the nice hemosiderin deposition, which is noticeable over here. So that is again an example of a dermatofibroma. So let's see some more examples. This is the one which is getting very cellular. But again, as I said, the more hemorrhagic it becomes, the more pigment it has, the more likely benign it is going to be. So anytime you see a pigmented tumor which has lots of blood and hemosiderin, it's likely going to be a DF. Then go back on low power and confirm. There is induction. You can see the peripheral collagen trapping within the lesion. You can see these giant cells within the lesion, the hemorrhage and the hemosiderin. You can see plenty of giant cells. Some of them may even have a two-tone morphology, as you can see in over here. This is again a dermatofibroma with hemorrhage. That's also referred to as a hemosiderotic dermatofibroma. Now, there is a variant of a dermatofibroma which I have talked about before with you guys, and that is an aneurysmal dermatofibroma. An aneurysmal dermatofibroma is also referred to as aneurysmal fibrous histiocytoma. These lesions are very cellular and they have tons and tons of hemorrhage within them. So when you look at low power on this lesion, it looks really scary and you're very tempted to pick it up to be malignant. What is striking about this lesion is these large areas of hemorrhage within the lesion and the marked increase in the cellularity. But when you look up in the cellular areas, they actually do not, they're just cellular. It's not ugly. It's not very mitotically active. For one of the rule to call something a malignant soft tissue tumor or sarcoma is it should have combination of three things. It should have cellularity, it should have cytologic atypia, and it should have mitotic activity. When all the three things are present, then it's very indicative of a sarcoma. If even one of the things is lacking, then it's not a sarcoma. So the three things are cellularity, cytologic atypia, and mitosis. So this lesion is just cellular. It's not atypical and it's not mitotically active. And it has tons and tons of areas of hemorrhage within the lesion. That's an aneurysmal fibrous histiocytoma or an aneurysmal variant of a dermatofibroma. These tend to be mimickers of malignancy. Remember, DFSPs do not have hemorrhage. They are not hemorrhagic tumors. So the more hemorrhage you see, the more likely it is going to be a dermatofibroma. Okay, so this is another example.
Dr. Anand, I have a quick question.
Yes.
So that rule with the malignancy of like cellularity, cytologic atypia, and mitotic activity, is that only true of malignant tumors that are mutated rather than translocated?
That's a good question. I don't know if I can generalize it like that, but the exceptions to what I talked about are low grade, are what is known as the monomorphic sarcomas. In the monomorphic sarcomas are three tumors, which are DFSP, synovial sarcoma, and DFSP, synovial sarcoma, and malignant peripheral nerve sheath tumor, which are so like DFSP is basically cellular. It is not cytologically atypical. It is translocation driven, and it is mitotically active, but not a whole lot of mitotic activity is seen. Malignant peripheral nerve synovial sarcoma is also translocation driven. It is monomorphic, so it is not atypical, but it is cellular and it is cytologically cellular and mitotically active, but not cytologically atypical, and it is translocation driven. Malignant peripheral nerve sheath tumor is not translocation driven, but it is cellular and not cytologically atypical and not very pleomorphically ugly looking. So I wouldn't generalize that rule, but kind of that may be true, but not always. For your purposes, what I want you to remember is the monomorphic sarcomas. And when I was going to come to DFSP, I was going to tell you that the three monomorphic sarcomas, which look not that ugly, but are just cellular, are DFSP, synovial sarcoma, and malignant peripheral nerve sheath tumor. Out of which the only board testable for you guys is going to be DFSP, is not going to be MPNST and synovial sarcoma. Those are most often distractors on your board questions.
Mhm.
Okay. So this is an angiomatoid. Again, you can see it often comes off in a piecemeal fashion. This is an important question. And you can see the increased areas of hemorrhage within the lesion. There's lots of hemosiderin, but again, you just see cellularity. There is not atypia and there is not mitotic activity. That is an aneurysmal fibrous histiocytoma. I want you to beware because often when they put aneurysmal fibrous histiocytoma, they put this entity in the differential diagnosis, which is your angiomatoid fibrous histiocytoma. Uh, it is there. It is there somewhere in here. The angiomatoid fibrous histiocytoma, yeah, right here. So you can see the similarity in the name. It's an aneurysmal fibrous histiocytoma is what I showed you, which is benign. And the angiomatoid fibrous histiocytoma is actually a low-grade malignant fibrohistiocytic tumor, which has this specific translocation, which you're supposed to know. But don't get confused with the name. They're very similar sounding name. That tumor looks completely different. Okay. The there's other variants of a dermatofibroma which we often recommend should be excised, and that's a cellular dermatofibroma. The cellular dermatofibromas have an increased risk of local recurrence. They're not malignant. They are more common in the head and neck region, and you again see a dermatofibroma which is much more cellular. But again, it has limited infiltration into the fat. It doesn't show the nice chicken wire pattern of fat entrapment, which we will see in a DFSP. It is a cellular tumor, but at the same time, it lacks the cytologic atypia. It can be mitotically active, but you often see pleomorphism. So again, pleomorphism is something which is not seen in a DFSP, right? So it makes you think about benign. And the most important marker in this would be a CD34. CD34 immunohistochemical stain is going to be absent in a cellular dermatofibroma, where it is going to be strongly positive in a DFSP. But you can also see its limited extension into the fat. So it's just a cellular dermatofibroma and not a malignant proliferation. Okay. There is now let's talk about a DFSP. So this is a DFSP. So a DFSP is again an intermediate grade malignant tumor, which is a very important board testable tumor, and it is also it's one of the most common soft tissue sarcomas that you see. So in the skin. So it is a skin-based sarcoma. So you do not get a lot of skin-based sarcoma. So as I said, the skin-based sarcomas that you typically encounter are DFSP, AFX/pleomorphic dermal sarcoma, and leiomyosarcoma. Those three are the most common ones. So that is why they are important. So a DFSP comes in the category of a monomorphic sarcoma. And as I said, monomorphic sarcoma, you may want to write them down, are DFSP, synovial sarcoma, and malignant peripheral nerve sheath tumor. So what does it mean? Monomorphic sarcomas means that they are cellular, but they lack the cytologic atypia. So they're not ugly. Okay. So you can see a DFSP has a very monotonous proliferation, cellular proliferation of the spindle cells with scattered mitoses, but it doesn't have a whole lot of hotspot of mitoses. It is mitotically active, but not a whole lot. It is intermediate mitotic activity. But the most important thing is the cellularity and the way you will see it entraps the fat. This is known as the chicken wire pattern of fat entrapment. You can see how it has produced the fat entrapment within the lesion. It's a chicken wire pattern of fat entrapment, and this increased cellularity, proliferation of very monomorphous, monotonous looking spindle cells in what is often described as a storiform or a wheel-like pattern. So they are present in fascicles, but sometimes they are also arranged as if they are kind of twirling around. That's called a storiform pattern. So I'm going to show you more examples. This is most often translocation driven, and you all guys know what is the translocation associated with it. 1722, platelet-derived growth factor beta and collagen 1 alpha 1. So that's the most important question that they like to ask you. But you see that it can have the induction, but it lacks the the cytologic atypia, the inflammation, the hemorrhage. It's another example of a DSP, a very nice example. So you can see if you do a shave biopsy of a DFSP, it can look very much like a DF. Why? Because you can see the epidermal induction, and in a shave biopsy, it may not look that cellular. So you can see it can be very misleading. So hence it is very important to either do a punch or to take out the lesion. If you're worried about a DFSP, please do not do a shave. And you can see how it can completely mislead you for a dermatofibroma. So again, you can see this very monotonous cellular proliferation of spindle cells with the nice chicken wire pattern of fat entrapment with no inflammation and hemorrhage. Is this clear to you guys? DFSP is something which is very important. It will absolutely be tested on your boards. And I will show you the staining pattern of a DFSP. Let's see another nice example with the storiform pattern. This is another very beautiful example of a DFSP. You can again see it often has some degree of induction, and it may not be very uniformly very cellular. And that is why it is important to get a good sample. You can see it doesn't look very cellular in these regions. The more cellular areas are basically down over here, where you see the nice entrapment of the fat within the lesion. But you can see how this is a beautiful pattern of the chicken wire pattern of fat entrapment. Again, very cellular, but not pleomorphic, and not no other component of cells. No mast cells, no inflammation, no hemorrhage. That is your DFSP. And this is how the CD34 will stain it. That staining is very, very classic. It is diffuse, strong staining. Not many tumors in soft tissue pathology will stain like this. So this is the CD34. You can see the dense diffuse staining, back-to-back staining in a DFSP with CD34. Do you have any questions? This is very, very important, understanding the differences between a DF and a DFSP.
Dr. Anand, do you mind just explaining what you mean by induction?
Yes. So induction means, let's go back. It was a nice example of induction, I think. Yeah. So induction means, okay, let's see what is normal epidermis in here. There isn't much normal epidermis. Okay, everybody can recognize that this is not normal epidermis, right? So induction is a pattern in which there are changes induced in the epidermis by something happening in the dermis. And most often, epidermal induction occurs in the form of delicate epidermal papillomatosis, where you get these broad fused rooty ridges. It is also known as a table topping. It looks like there is a table, top of a table overlying a lesion. That is what is referred to as induction. It's just epidermal proliferation with papillomatosis with fused rooty ridges. You see that?
Yes, thank you so much.
That's epidermal induction. So that can be seen as most often seen in a DF, but it can also be seen in a DFSP. Okay.
Can you explain what a chicken wire pattern of fat entrapment is?
What the chicken wire pattern of fat entrapment is? Yes. So the chicken wire, this is what a chicken wire pattern of fat entrapment is. You see here, this is all the fat within the lesion, and it's all obliterated because there is proliferation of spindle cells which is encasing the fat. So what it basically is entrapped fat within the spindle cell proliferation, because it's a malignant tumor, so it nicely percolates around the fat. So you see, like the spindle cell tumor, the background of the fat is lost, and what you just see is there's some adipocytes lying which are entrapped within the malignant proliferation. That's the chicken wire pattern of fat entrapment.
Okay, so there's just like random globules of fat in the dermis that like look out of place and are
yes, exactly. That's because it's obliterating the fat, right? It's a malignant proliferation. It will seep down the fat, and that's why it is very difficult to excise it just based on excision. You need to do more surgery for this.
Okay, thank you.
Okay, so now let's come to your next. Now will be some entities which, if you see it once, you will always remember it. So again, a very high yield board question. When you see these kind of cleft-like spaces of hyalinized collagen bundle with hypocellular proliferation of fibrohistiocytic spindle cells, that is your sclerotic fibroma or circumscribed storiform collagenoma. This is associated with Cowden syndrome. So it's a very, very important board tumor. It has a very classic appearance. It looks a very hypocellular hyalinized tumor with these cleft-like cracked hyalinized spaces. And that is your sclerotic fibroma or circumscribed storiform collagenoma, which is associated with Cowden syndrome. Okay. Let's go into the next one. Also very important board entity is nodular fasciitis. So nodular fasciitis is a reactive entity. It's not even a tumor. It occurs on sites which are prone to trauma. So you can see it on the head and neck region in kids when they hit their head against the they get injured, like say in the in the cradles. So that's also known as the cradle fasciitis, or in elderly individuals on the extremity, so the elbow, the sites which are prone to trauma. So the rules about nodular fasciitis is that these lesions are always located in the subcutaneous fat. That's the number one rule. Number two rule is they are circumscribed but not encapsulated, and small lesions, typically less than 5 centimeters. So they're not huge lesions. The next rule is that these lesions will actually spontaneously regress. So even if you incompletely excise them or take them out, they will spontaneously regress. They do not come back. So if a lesion which has been diagnosed as nodular fasciitis keeps on coming back, then it's not nodular fasciitis. Okay, so those are the general rules you should always remember. So the subcutaneous location is very important. Very rarely you get it in the dermis, but I would say that is an exception rather than a rule. So it is almost always in the subcutaneous fat. In the subcutaneous fat, you can see that there is an increased area of cellularity, and it is not encapsulated, but it is a well circumscribed lesion. The lesion has zonation. So you can see that there are increased areas of cellularity and less areas of cellularity within the lesion. This is pretty classic. The increased areas of cellularity are the newly formed areas, and the older areas, they tend to become more fibrotic and hyalinized. So let's go to the areas of increased cellularity. So when you go to the areas of increased cellularity, you see this proliferation of, again, fibrohistiocytic spindle cells, which are kind of, in this case, going in a north-south direction. And in areas like this, they are going in an east-west direction. When you see nuclei, which are kind of aggregating together to either go up or to either go down in one single plane, that is always indicated that it's reactive. It's being laid down because of trauma, like what you saw in a scar. Again, the fibrohistiocytic spindle cells are very non-discrete. It looks like the stroma is very loose. It is a kind of myxoid. It has areas of hemorrhage within it. And that is what is known as the tissue culture effect. It looks like granulation tissue. It looks like the fibrous tissue is being laid down as a response to trauma. So you can see some edema. You can see some fibromucinous change. You can see areas of hemorrhage. Because it is a reactive phenomenon, it can have atypia. So if you stare too much at the fibrohistiocytic cells, they will start looking ugly. They can be mitotically active. They can have giant cells within the lesion. You can see the pleomorphism, the atypia within the lesion. So it's important to make your impression on low power. When you see a lesion which is within the fat, which has areas of zonation within it, as you can see in here, the cellular areas, they look like granulation tissue. You can see the nuclei. In this case, they are very fresh, so they are not very banal looking. They have prominent nuclei, but it's all in the background of this hemorrhage, microcystic edematous change. There is some fibromucinous change, and you can see in the more well-formed areas, it's kind of dying down. So it's less cellular, it is getting hyalinized, and is forming collagen. So that is nodular fasciitis. So now I'm going to show you some more examples. Again, this is a very, very important board entity that tends to be asked. And again, example of nodular fasciitis, you can see that the lesion is entirely located within the fat. It has areas of zonation. So you can see here, this is the older areas where you just see like a scar kind of a phenomenon with areas of hemorrhage. Again, the north-south direction of the fibroblastic nuclei. This is the more fresher areas. Beautiful tissue culture effect. You can see the nice fibromucinous change in the background. There is hemorrhage. The cells are going in the north-south direction. Microcystic change, variable degree of inflammation, and hyalinization within the lesion. So, but the lesion is entirely located within the fat. So this is nodular fasciitis. You can again see the higher you go, the more atypical it will become. It can have mitotic activity, so you have to restrict yourself to low power. Let me show you again a really good example. This is a nodular fasciitis. Again, you can see that it has come out in a piecemeal fashion. There is the epidermis over here. The lesion is entirely located within the fat. It's a beautiful example. You can see the nice areas of zonation, the pinker areas and the more cellular areas to go up. This is as classic as it can get for tissue culture effect. Okay, the loose stroma, the delicate fibroblastic cells, sprinkle of inflammation, hemorrhage, edema, granulation tissue. You can take a screenshot of this. This is so beautiful for tissue culture effect, what is seen in nodular fasciitis. So this is benign. Whenever they show you this, they will try to confuse you with myxoid malignant fibrocystocytoma. So again, remember your zebra tumors that they try to confuse you with this, which are almost always the wrong answers. Okay, so that is nodular fasciitis, a very, very important board question. Okay, coming to the next one, which is again also very high yield, is a giant cell tumor of the tendon sheath. Giant cell tumor of the tendon sheath is going to occur on the acral side. So you're going to see thick skin. As you can see in over here, you can see the thick skin. And you can see here a multinodular, multilobulated tumor, which is entirely within the dermis. And it can also go down into the fat, not a problem. It's a very easy diagnosis to make if you're thinking about in terms of location. What is a tumor on acral skin? Acral skin, multinodular tumor looks very cellular. When you go up on high power, you often see areas of hemorrhage within the lesion. So there is hemosiderin. But what you are struck by are these monotonous proliferation of these mononuclear epithelioid cells. So right now, what we have seen are spindle cells. But these are mononuclear epithelioid cells, right? And they're mononuclear epithelioid cells. They're all monotonous, all looking like one another. Mononuclear epithelioid cells. You keep on moving around. And then you're going to see multinucleated osteoclast-like giant cells like this, which have the same nuclei like the outside. So like those cells just collect together to form these multinucleated osteoclast-like giant cells. You can see here one. There's a beautiful example right there. So again, a multinodular tumor on acral skin with areas of hemorrhage and hemosiderin, proliferation of monotonous mononuclear epithelioid cells. Mononuclear epithelial, remember that, mononuclear epithelioid cells, and scattered in the background of which are going to be these osteoclast-like giant cells which have the same nuclei as the outside. That is your giant cell tumor of tendon sheath.
Doctor,
now, these tumors can be mitotically, yes, Maria?
can you explain what an epithelioid cell is? Like, I think we use that word a lot, and I don't think we've ever defined it.
Yes. So the when you look at the nucleus of a cell, you broadly classify it as a spindle cell or as an epithelioid cell. A spindle cell is when it has a spindle nuclei. So like all the other tumors that we have seen right now, if you look at the nucleus of this, what does the nucleus look like? It's elongated, right? So this is known as a spindle cell. When you refer to as a spindle cell, you are referring to a mesenchymal origin. So it could be fatty, it could be fibrohistiocytic, it could be neural, it could be smooth muscle, it could be vascular. Okay, that's a spindle cell. So you're just referring to the type of the nucleus being formed. On the other hand, when you are looking at a nucleus and it has a rounded morphology, not a nuclear, not a spindle morphology, that is referred to as an epithelioid cell. An epithelioid cell could be either epithelial in origin, which is most often, which is, for example, melanocyte or a keratinocyte. So you can see they have round nucleus. Or it could still be a spindle cell. Like this is a spindle cell tumor, but it has an epithelioid nucleus. So that is why it is called an epithelioid. So epithelioid is just referring to the nuclear morphology, whether it is round or whether it is spindle cell. Do you get that?
Yes, and I'll send pictures in our group chat, but that tends to be like a point of confusion for everyone. So just to give like an example, like melanocytes, for example, can be both epithelioid or spindled. They tend to be more plump and epithelioid, like closer to the epidermis, and then like they can get more spindled, like in nodular melanomas. But it's
or even in a blue nevus.
Yeah, exactly. So like epithelioid versus spindle does not tell you the cell type that it is.
No.
It describes a morphology.
Just the nucleus.
Exactly. So
yep, you can have anything becoming epithelial, like for example, like a polydifferentiated sarcoma, spindle cell squamous cell sarcoma, sarcomatoid squamous cell sarcomas, they are spindled, right? but it is epithelial in derivation. So when you are referring to a spindle and epithelioid, you're just referring to the nuclear morphology. It's more of a morphologic description. Okay, so here this is a spindle cell tumor, but it is made up of epithelioid cells, monotonous epithelioid cells, which will have those osteoclast-like multinucleated giant cells. So that was giant cell tumor of the tendon sheath. The next thing which we are going to talk about is your fibromatosis. So fibromatosis, which dermatologists encountered, are the peripheral fibromatosis. They can also be central fibromatosis, which is referred to as desmoid tumors, which is what you see in like a Gardner syndrome or in which you guys don't encounter. The central fibromatosis or the desmoid tumors have a beta-catenin mutation, whereas the peripheral fibromatosis, which included in which are are entities like Dupuytren's contracture, Peyronie's disease, Ledderhose disease, Palmar plantar fasciitis, all of those entities, they are not even tumors, but they are locally aggressive, and that's what you guys deal with, and that's the morphology that they will ask you. So fibromatosis, most often podiatrists is where we get the samples from. You will often come out in a piecemeal fashion. So you can see here pieces of tissue because there is no defining border of the lesion. You can never get rid of the lesion per se, right? When you go up on high power, it's elongated fascicles of proliferation of very monotonous looking fibrohistiocytic cells. They're all proliferating in a single category, in a single direction. There is not much atypia at all. It's like the proliferation does not end. It keeps on going on and on. You just see this kind of sheets of proliferation of fibrohistiocytic spindle cells in a single direction with the dense hyalinized stroma in between them. That is fibromatosis. And that is the peripheral fibromatosis like Dupuytren's contracture, Peyronie's, Ledderhose disease is what you deal with. Okay, that is fibromatosis. The next one we are going to talk about we have learned about this, is an acquired digital fibrokeratoma versus an accessory digit. So both these lesions have a similar morphology. They both look like polypoid lesions with very thick stratum corneum. This is what is known as a pseudo nail appearance. The stratum corneum is so thick that it looks like an artificial nail. It is a polypoid lesion and has a nice epidermal collarette epithelial proliferation with marked hyperkeratosis and a hypocellular hyalinized stroma, as you can see in here. That's acquired digital fibrokeratoma. Now, how do you differentiate it from an accessory digit is you have to see hypertrophied nerve bundles for an accessory digit. So let's see this example. So this is again a polypoid lesion, similar to what you saw with the thick hyperkeratotic stratum corneum, the epidermal collarette, but within the stroma of the lesion, you see these hypertrophied nerve bundles. So you can see these are collection of nerve bundles. So that makes it an accessory digit as compared to an acquired digital fibrokeratoma. So that's an important distinction. Obviously, if the accessory digit has the whole digit part of it, if it has bone and cartilage within it, then makes it even diagnosis becomes even easier. So you can see here the cartilage is there within the lesion, but that's not the one that they like to show you. The one that they like to show you is the one that I just showed you, which is the one which just has the nerve bundles within the lesion. Where did that go? This one. So you can see the polypoid lesion with the fibrostroma with these hypertrophied nerve bundles within the lesion. So that's acquired digital fibrokeratoma versus an accessory digit. The next entity which we're going to talk about is rare, but for some reason it is a very important board question, and that's inclusion body fibromatosis or infantile digital fibromatosis. So as the name suggests, infantile digital fibromatosis or inclusion body fibromatosis is an entity which occurs on the digits of infants, so less than 2 years of age, and they can occur both on the hands and the feet. More common, I believe it's the feet, but you may want to check on that. So it's less than 2 years of age, lesions on the hands and the feet. So you will again get an acral lesion. So you can see the thick skin, and then there's proliferation of the fibrohistiocytic spindle cells within the lesion. The diagnosis is very simple because they will give you a hint. When they mention a kid and the digit, you're dealing with an infantile digital fibromatosis or inclusion body fibromatosis. So you'll see the proliferation of these fibrohistiocytic spindle cells within the dermis. And as soon as you go on high power, you will see these inclusion bodies. You see these inclusion bodies, these pink perinuclear inclusion bodies. They're going to be very prominent and distinct. You see that? Everybody seeing that? See these pink inclusion bodies within the lesion?
Is it
And
like a light pink?
No,
Yeah,
those are
okay.
spaces. You're
Oh,
looking that almost look like lesser dark red blood cells, like these.
they're
got
gonna
it.
ask you what it's made out of. And like,
Yes, so they look like red blood cells, and you need to know that they basically on electron microscopy they're composed of compact masses of actin granules, and they stain red with trichrome, and they also stain with like smooth muscle actin. Okay, so these are your inclusion bodies. It's a very simple diagnosis to make if you're thinking about it. You just have to put two and two together. It's a child, it's the digit, it's a thick skin. There is a fibrohistiocytic spindle cell tumor, and when you go up on high power, you will see all these inclusion bodies, which look like red blood cells, and they're perinuclear intracytoplasmic distribution. It's a bunch in here. Okay. Let's go to your next entity, which we have again talked about, and we are probably going to talk about it again when we will do your non-melanoma skin cancers, and that is an AFX. So atypical fibroxanthoma is again a malignant fibrohistiocytic spindle tumor which occurs in the skin. It exclusively occurs on the sun damaged site of the head and neck region. And what you see is a tumor which is very classic in its low power appearance. You will see a cellular spindle cell proliferation which abuts the overlying epidermis and looks like it is emanating from it. There is often background massive sun damage. So it occurs in the background of marked solar elastosis. The overlying epidermis can be atrophied, ulcerated, or it could be intact. So in this case, you can see the tumor abuts the epidermis and often arises from it. Now, the location of an AFX is very important. These tumors are located entirely within the upper and the mid-reticular dermis. They should not go into the deep dermis, and they should certainly not go into the fat. If these tumors go into the deep dermis and the fat, then you have to upgrade it to a pleomorphic dermal sarcoma. So an AFX is a tumor which is most often when you take a biopsy of this lesion, they are transected at the base. So that is why on a shave biopsy, before you excise it, we always have to leave the possibility that on the excision, the lesion can be upgraded to a pleomorphic dermal sarcoma. So pleomorphic dermal sarcoma and AFXs are essentially the same tumors in terms of their histology. The histology is proliferation of these markedly atypical spindle cells, which can have multinucleated giant cells. They're very ugly looking, very pleomorphic. You often have atypical mitoses within the lesion. You can have areas of hemorrhage within the lesion. And this is a diagnosis of exclusion, right? You have to make sure it's not a melanoma. So it has to be negative for S100, SOXTEN, and Melanase. You have to make sure it is not a polydifferentiated squamous cell carcinoma. So the three markers that we use are P40, pancytokeratine, and CAM5.2. All those three markers have to be negative. P40, pancytokeratine, the other name for which is cytokeratin AE1/3, and CAM5.2. You have to make sure it is not an angiosarcoma, so it's got to be negative for CD34, CD31, and then you have to make sure it is as well as ERG, and a leiomyosarcoma, so it is negative for SMA and Desmin. Okay, AFXs show non-specific staining with CD10, CD68, and procollagen 1. Other question that can be asked is that AFX can also show some non-specific staining with SMA, smooth muscle actin, and ERG or ERG, which are muscular and vascular markers respectively. Okay, this is how exactly a pleomorphic dermal sarcoma will also stain. But the pleomorphic dermal sarcoma, you make the diagnosis because on excision, this tumor goes into the deep fat and often into the deep dermis and the fat. It can have areas of perineural and lymphovascular invasion. Now, why is that distinction important? The distinction is important because AFXs, they are malignant tumors, but they don't metastasize and they don't recur. Okay, once you take them out, they are treated. But a pleomorphic dermal sarcoma, if you upgrade an AFX to pleomorphic dermal sarcoma, that lesion needs to be followed because those lesions can recur and they can also metastasize. So they're true sarcomas. But otherwise, the staining and the histology of the lesions is similar. Okay, so do you guys have any questions on what I asked you? So you should know about the staining. What, like, you have to make sure it's not a melanoma, a squamous cell carcinoma, a leiomyosarcoma, and an angiosarcoma. Remember, it shows non-specific staining with CD10, procollagen 1, and CD68. And it can also show non-specific staining with SMA, which is a muscle marker, and ERG, which is a vascular marker. So those are all the questions that can be asked.
For the phenotype of like what it looks like in the cells, they often talk about like the four cell types, or the four like phenotypes of what the cells look like as an AFX. Can you just like point them out if it's important?
It's not important because AFXs, they can actually look like a wide variety of type. So when you look at the cytology of the cells themselves, so that is why I think the morphology on low power is very important. A tumor abutting the epidermis, background sun damage, diffuse cellular proliferation. In terms of the types, I can tell you, I have seen AFXs looking like a whole lot of things. The most classic is when they have a spindle morphology. They can have an epithelioid morphology. They can have a hypocellular morphology. So they may not be that cellular. There's some scattered cytologic atypia. They can have a clear cell morphology that is much more beyond the scope of, what basically can be board tested. It is going to be, so that is why the most important thing is recognition on low power. What is the uniformity is the low power appearance and the atypia of the lesion. The type of the cells, they can be variable. It is predominantly spindle cell. Did I lose you guys?
No, we're here.
Oh, okay, sorry. I don't know what happened. It disappeared from my screen. Hold on. Okay, here you guys are. I don't know what happened. Okay. So the cytology of the cells can be is ugly. That is the uniformity. But the type, whether they are spindle or they are epithelioid or the clear cells, it can vary.
And then one other thing, this lesion is obviously ulcerated, and I think we're having trouble picking up on ulcers. And like, can you just describe like how an ulcer looks and like how that is like a diagnostic clue for like a lot of entities like PG, AFX, etc.
So an ulcer is first of all, not all AFXs are ulcerated. They can be, but they may not always be. Ulceration is just the loss of the surface epidermis. So like what you see in over here, you can see the epidermis, right? And then you trace the epidermis and then boom, it is lost. Now you don't see any epidermis. Instead of the epidermis, you have crust. You have serum and crust and hemorrhage, which is overlying the lesion. So loss of epidermis is ulceration.
Do you guys see how this is an ulcer like this right in front of you? And like how when we saw all those pictures of a PG, how that was ulcerated, like it looks like this.
If you don't see the epidermis, then there has to be something overlying it, right? Because the body has to react. So think about it clinically. What do you see? You don't see the epi, but you see all that grunge and the debris. That grunge and the debris is the serum and crust and hemorrhage. That's what overlies the lesion, but you do not have the epidermis.
Right, like this is not epidermis. This is just a collection of neutrophils and blood that is just like
Exactly.
top.
There is no epithelium overlying it. It's just inflammation and serum and crust.
Yep. And PG
Okay.
also has this look.
Okay, so the next one, which is a very rare tumor, which, honestly, like probably see it once, like in 2 or 3 years, is a dermatomyofibroma. But they like to test you on your boards. This lesion is more common again in younger individuals, and it is the shoulder region. Upper extremity is a common location, and the lesion has a biphasic morphology. So the top of the lesion looks like it is perpendicular to the epidermis, and the bottom looks like it is parallel to the epidermis. Dermatomyofibroma, it is like a fusion between, if you look at the cells, they are fibrohistiocytic. So they have this non-discrete nuclei, but they're also kind of you may say it has got some smooth muscle phenotype because they are arranged in fascicles. So when you talk about the smooth muscle bundles, we will see that they like to be arranged in fascicles with some tapering nuclei. So it is a lesion which has an overlapping morphology. It is fibrohistiocytic, but with some muscle features within it, and hence it is known as a dermatomyofibroma. But the way you recognize the lesion is the two placed morphology of the bundles. So the top of the lesion, which is oriented perpendicular to the epidermis, and the bottom, which is laid down parallel to the epidermis. That is your dermatomyofibroma. It's again one of those lesions, if you have seen it once, you should probably remember it. Okay. The next one we are going to talk about is your, I think I did this. Okay. The myofibroma. So that is another, it's a rare tumor, but it has a very striking morphologic appearance. Again, it's one of those entities, if you've seen it once, you will always remember it. So the myofibroma is a tumor which again occurs most often on the legs, and it is a multinodular tumor. So remember the adnexal, the only adnexal tumor which has a chondromyxoid stroma, which looks like cartilage within the lesion. The chondromyxoid stroma, which has cartilage within the lesion, as you can see in over here. Like it looks like it has cartilage is what? What is the adnexal tumor which looks has a chondromyxoid stroma?
Chondrosyringoma.
Exactly. So that stroma, if you put in a soft tissue tumor, that is a myofibroma. So this tumor is a multinodular tumor, like you look like this, and then the stroma has this chondromyxoid look to it, as you can see in over here. These semilunar crescentic vessels. Do you see that?
Yes.
So this tumor is actually arising from the wall of these vessels, which are known as the hemangiopericytomatous vessels. So these slit-like semilunar vessels arising from the wall of this is going to be this multinodular proliferation, which has this chondromyxoid stroma, as you can see in over here. So again, these slit-like hemangiopericytomatous vessels with this multinodular proliferation arising from the wall of the vessel. So that is your myofibroma. This stroma of the lesion is actually arising from the wall of these vessels. So that is why it is because if you stain it with smooth muscle actin, this will stain up. So so again, the appearance of the lesion is important. It's a multinodular appearance with the chondromyxoid stroma, and you can see at the periphery of the lobules is this crescentic semilunar vessels. That is a myofibroma. Again, a very classic appearance. If you've seen it once, you will always remember it. The next entity we are going to talk about is an angiofibroma. So angiofibroma, the other common name of it is in fibrous papule. This is the tumor of tuberous sclerosis. So the adenoma sebaceum in a tuberous sclerosis is an angiofibroma. So adenoma sebaceum is a misnomer. So often a polypoid tumor, and as the name suggests, angiofibroma. So it has the angio part of it, which is the vessels, and the fibrous part of it. So the fibrous and it's a nice appearance. Like you look like the nice polypoid lesion, you have the ectatic vessels, and then you have this fibrous tissue within the stroma. Often the fibrohistiocytic cells, they are angulated. This is called a stellate morphology, like they have pointed nuclei. They are like triangular shaped. Again, the low power view of the lesion is important. So this is an angiofibroma, or the adenoma sebaceum of tuberous sclerosis. This is another example. You can again see the nice polypoid lesion. You can see the nice vascular part of the lesion. And this is the fibroblast that I was referring to. These are the angulated or stellate fibroblasts, which make up an angiofibroma. Okay, angiofibromas, again, they can undergo different kinds of change. They can undergo a granular cell change, a clear cell change, again, which is, beyond, like it is a more higher level derm path. Just remember a plain looking angiofibroma, which is important. Okay, the next one is an oral fibroma. The oral fibroma is the one that occurs in your oral mucosa. So first of all, recognize the site, the mucosa, because it doesn't have the granular cell layer. And this is again a fibrous lesion, a hypocellular fibrous lesion, which occurs in the mucosal cavity. Again, nothing looks like that, right? An irritation fibroma, a bite fibroma, and oral fibroma will all look the same. Oral mucosa with fibrous proliferation. The next one I'm going to be talking about is now this is rare. If you want to forget it, that's completely fine. This is known as an ossifying fibromyxoid tumor. It has a piece of bone overlying the lesion, and then within the stroma, you can see this fibrohistiocytic proliferation of spindle cells, which is pretty monomorphous, as you can see in over here. You can skip this lesion. I'm not going to go in detail because this is extremely rare, and again, more of a derm-path specific kind of a question. Okay, so now let's go into your smooth muscle tumors. So smooth muscle tumors, again, are very important, are very high yield questions. So first of all, the smooth muscle tumors, let's understand the morphology of a smooth muscle tumor. The smooth muscle tumors are always going to be very pink, okay? And they're always arranged in fascicles. So you can see here a collection of smooth muscle cells. So that's known as a fascicle. This is one fascicle. This is another fascicle. So the fascicular arrangement of the spindle cells is very important. Bundles of smooth muscle spindle cells, one fascicle and another fascicle. The morphology of the spindle cells, like how do they look? They have these cigar-shaped nuclei. So you can see this nucleus, it is pointed at one end and it is oval at the other end. That is your cigar-shaped nucleus. And you can see that these cells, they have a lot of cytoplasm because their function is contraction, right? So they have a lot of actin protein within them. So that is why they look really pink. So again, the morphology that they are present in fascicles and bundles, and they are very pink looking with the cigar-shaped nucleus. So the leiomyoma, so when you look at the tumor on low power, it is going to look like a really pink tumor. So you can see here, this is a tumor. They are often not very, they are circumscribed, but not completely well circumscribed. You notice that the tumor is very pink in the dermis, and when you go up on high power, again, the fascicular arrangement of the spindle cells is very important. They're arranged in fascicles. So this is one fascicle, this is another fascicle. Again, the nuclei, you can see the cytology, the cigar-shaped nucleus with lots of pink cytoplasm. Now, when the fascicles are arranged the way that they are cut, right, they often produce these perinuclear cytoplasmic vacuoles. So you can see here, these kind of perinuclear spaces, which are white spaces. These are known as lollipop cells. They look like little lollipops. This is because of the way the fascicles are basically cut. So that is another morphology. So this is a leiomyoma. The same thing is what you would see in a leiomyosarcoma, the same arrangement, except that you will have increased, remember, sarcoma should have three things. So it should have increased cellularity, the atypia, and the mitosis. That will make it a leiomyosarcoma. The same looking cells, but they are ugly. They are mitotically active, and they are cellular. So that will be a leiomyosarcoma. So this is a leiomyoma. Let's go to another example. You can again see this one is very well circumscribed, again, a very pink tumor within the dermis. And you go up on high power, you again see the fascicles of the spindle cells. You can see the nice fascicles, the spindle-shaped nuclei. You can again see the perinuclear cytoplasmic vacuoles or the lollipop cells with lots of pink cytoplasm, but there is no atypia within the lesion. That is your leiomyoma. The malignant counterpart of it is a leiomyosarcoma. So again, what you see in here is, so this is again a soft tissue malignancy which occurs in the skin. A DFSP, AFX, and a leiomyosarcoma. So it is a dermal-based sarcoma. So you can again see that there is increased cellularity in the dermis. When you go up on high power, you again notice the fascicular arrangement. Are you seeing the fascicles? The collection of the spindle cells, the fascicles?
Yes.
But they are more cellular. So now they have much more increased cellularity. You have cytologic atypia. So you have all the features. Now I'm looking for mitosis. So let's try to find a mitosis. And you see the mitosis. Here's a mitotic figure here. There's another mitotic figure here. So it fulfills the criteria, the atypia, the cellularity, and the mitosis. So that is your leiomyosarcoma. Now, remember that your leiomyosarcomas are classified as dermal and subcutaneous. So the dermal leiomyosarcomas, the cutoff for the size is 5 centimeter. If it's in the dermis, if it's less than 5 centimeter, many people refer to even not call it a leiomyosarcoma, but to call it an atypical leiomyomatous tumor because they can be completely excised and they will not recur. Okay, so even though they are malignant, they have a very good prognosis. That's a dermal leiomyosarcoma. On the other hand, if the location is in the fat, if it is greater than 5 centimeter, if it is incompletely excised, then those are true malignant leiomyosarcomas which can recur, which can metastasize. Okay, and in a subcutaneous leiomyosarcoma, you have to make sure it is not a metastatic process. So a metastatic process, say from the uterus in case of a female or from a vessel, needs to be excluded. Okay, so those are the second great questions that they like to ask you. The location determines the prognosis, so dermis versus subcutaneous tissue, the circumscription, whether it is incompletely or completely excised, and the size, which is the 5 centimeter, which is the cutoff size. I'll show you another example of a leiomyosarcoma. So this one is actually in the deep fat. So this is a subcutaneous leiomyosarcoma. So this will be a higher grade lesion. When you again go up on high power, you can again see the fascicular arrangement of the spindle cells, but they have the atypia, they have the cellularity. So this is and they also have some scattered mitoses. So this is going to be a leiomyosarcoma. The nice fascicular arrangement, you can see that. You can see that they are arranged in bundles or in fascicles, but they are clearly atypical and cellular looking. So that is your leiomyosarcoma.
Dr. Anand, I thought the leiomyosarcomas were supposed to like slam against the epidermis, like it's part of the
Nope.
differential.
Nope.
Okay.
No,
Like-
not at all. Leiomyosarcomas, which are based in the dermis, are most often arise from the erecta pili smooth muscle bundles. So they will not abut against the epidermis. They may, but that's definitely not a criteria. The
Okay.
leiomyosarcomas can be dermal or subcutaneous fat, and that is actually a prognostic differentiating factor, and hence it's an important concept and an important question to understand.
Okay, thanks.
Okay. The next one, which we have again talked about before, is an angioleiomyoma. Now that's like one of, again, a very nice favorite board question that they like to ask you. These are benign tumors. These most often are located on they're painful tumors on the lower extremities. They come off in a piecemeal fashion. They are well circumscribed but not encapsulated. And you can see that they are these bundles of pink smooth muscle spindle cells, which are like arising an association with the vessels. So they have a vascular component and hence angioleiomyoma. The vessels are often compressed or slit-like, and arising from the walls of the vessel are going to be these fascicles of these smooth muscle spindle cells. You can again see that they are very, very pink because of lots of cytoplasm, and they're arranged in fascicles in association with these compressed vessels, as you can see in over here. So that is your angioleiomyoma. The low power appearance is again very important. Again, once you have seen it, you will always remember this lesion. So that's about the smooth muscle tumors, which is leiomyoma, leiomyosarcoma, and an angioleiomyoma. Let's come to your neural tumors. Okay, so the neural tumors, again, one of the most commonly encountered neural tumor is your neurofibroma. So first of all, the cytology of the neural tumors. The spindle cells in the neural tumor are very delicate and wavy. So you can see how very nicely delicate and elongated and spindly they are. That is what tells you that something is neural. They are not like larger and bulky like what you saw in a smooth muscle tumor. Neurofibroma is again a very common neural tumor. This tumor is well circumscribed but not encapsulated. You encounter 3 types of neurofibroma. This is the more conventional type that you routinely see. Then you can have a diffuse neurofibroma, which is more going down in the dermis and the fat, and a plexiform neurofibroma. So a diffuse neurofibroma, 20% of it can be associated with NF1, and a plexiform neurofibroma, 100% of them are associated with NF1. So that is important to know. So this is your classic neurofibroma, proliferation of delicate neuroid spindle cells. Mast cells are an integral component of the lesion. So you will always see mast cells within the lesion. And the background stroma is this delicate, often known as the chewing gum or the bubblegum kind of stroma. It's a very delicate fibromucinous stroma. That's your classic neurofibroma. Now, let me show you a diffuse neurofibroma. This becomes a little bit more challenging. A diffuse neurofibroma is the one which is a mimicker of a spindle cell lipoma and a DFSP. So you can see how this neurofibroma is going down into the fat. So you may think that this is a chicken wire pattern of fat entrapment, right, Maria? You see that?
Yeah, yep.
But when you go up on high power and you look at the cells, they look nothing like a DFSP, right? They look very delicate, neuroid, the background spindle cells, and then location for the mast cells is going to become important. So you see the mast cells? See the mast cells? So you will never ever see that in a DFSP, right? So this is a diffuse neurofibroma. So you can see that it is poorly circumscribed. It is going down into the fat. So that is why you may think it's a DFSP. But when you go up on high power, that clearly has mast cells. You have very neuroid, delicate looking spindle cells. This will be S100 SOX10 positive. It can also be CD34 positive. But it has the mast cells. The cytology of the cells is different. So hence it's not a DFSP. This is a diffuse neurofibroma, which is the more common board testable one and is associated with NF1 in 20% of cases. The next one is going to be your plexiform neurofibroma. Plexiform neurofibroma refers to the architecture of the lesion. So what you see here are bag of worms. So you can see here these plexiform nodules. These look like little worms. This is one worm. This is another worm, another worm, another worm, another worm. So they look like little bag of worms. When you go up on high power, within the worms itself, they have these delicate neuroid spindle cells. So this is a plexiform neurofibroma. When you call something a plexiform neurofibroma, that has 100% association with neurofibromatosis 1. So it's important. Not plexiform schwannomas, but only plexiform neurofibromas, 100% association with neurofibromatosis 1. So plexiform, this is how it looks like. The bag of worms with proliferation of the neuroid spindle cells in the delicate stroma. Okay. The next benign spindle cell neural tumor, which we're going to talk about, is a schwannoma. So a schwannoma is a spindle cell tumor, is a neural tumor, which is very well circumscribed, and it is the only one which is encapsulated. So you have a definitive capsule around the lesion. So you can see the capsule around the lesion. Most often, these lesions are going to be occurring in the deep dermis or in the fat. And what you see are these areas, the hyper and the hypocellular area, so the varying areas of cellularity. Guys, can you just give me a minute? I just want to check on my son.
For sure.
1 minute. Hello? Are you going to go? Oh, okay. So come back. Okay, you gave them the necessary stuff. Okay, okay. Thank you. Bye. Okay. So you can see the areas of hyper and hypocellularity. So you have increased areas of increased cellularity, the increased lesser areas of cellularity. And the these are known as the increased areas of cellularity are the Antony A, and the lesser areas of cellularity are the Antony B areas. So another important feature is the Verrucke body. So what is a Verrucke body? Verrucke body is like when the nuclei, they line up against one another and form little stacks or bundles. So you can see here nucleus like lining up like this. This is a Verrucke body. Okay, this is another Verrucke body. You can see the nuclei lining up against one another. So the Verrucke bodies are going to be seen in the Antony A areas. The Antony B areas are these more kind of pinker, lesser cellular areas. So the classic schwannomas will have both the Antony A and the Antony B areas, the hyper and the hyper. So the nice and the Verrucke body. So you can see the nuclei, they are lining up against one another. Another important feature of a schwannoma is the presence of hyalinized vessels. So the vessels are often very hyalinized and ectatic within the lesion. So these lesions often have dilated vessels which have perivascular hyalinization, as you can see in here. So let me show you more examples of a schwannoma. This is definitely an important board question. So let's see more examples. You can again see a very well circumscribed lesion. In fact, what you see in here is the marked vascularity of the lesion. There are a lot of like hyalinized vessels within the lesion, and there is perivascular hyalinization, as you can see in here. Perivascular hyalinization within the lesion, lots of increased cellularity. You can see that there is okay, another thing about a schwannoma is a schwannoma can have pleomorphism. What happens is as the lesion becomes older, the nuclei degenerate and become hyperchromatic. So this lesion, when you look at it, it can look cellular and a little ugly. So beware of it. When you see, so that is why things like looking at the vessels, the hyalinization of the vessels, the circumscription of the lesion, and these are the Verrucke bodies. You can see how the nuclei are lining up against one another like this. So that is a schwannoma, but you can see that some of them have this random atypia. They are enlarged and they are hyperchromatic. Okay. Guys, I'm teaching you a whole lot today, but the best thing about soft tissue pathology is when I will give you the study sets, you really have to get your hands dirty into it till you actually look at the lesion and think about it on your own, knowing all the basic concepts. That is the only way it is going to solidify it. I know it can look like really daunting at times, but honestly, there is not many things that they are going to ask you on your boards. And knowing the concepts of what we are discussing today will be helpful. So you can again see that this lesion is well circumscribed. Again, look at the vessels within the lesion, right? They are the first pointing feature of the lesion. That they are very important in a schwannoma. Nobody talks about the vessels, but we should know about that, the vessels within the lesion. And you look at the background of the lesion, it starts looking like ugly, right? But you again see the nice stacking up of the nuclei. That's a very neural morphology. That's the Verrucke body right over here. And then the stroma can be variable. You have the hypocellular areas. This is again a nice Verrucke body. So that is your schwannoma. You should always go to the more classic looking areas where you can find the things like a Verrucke body. Okay. The next one, which is a simple one, which you guys are good at recognizing, is a palisaded encapsulated neuroma, PEN. The palisaded encapsulated neuroma occurs most often on the head and neck. This lesion has an artifactual cleft. So the lesion retracts from the surrounding stroma and it has a cleft-like space around it. Now, this lesion is well circumscribed with the cleft-like space around it. The inside of a palisaded encapsulated neuroma, it actually looks like a schwannoma. So you can see here the cells, they are looking like a schwannoma. They are spindly, neural. So the architecture is a cleft-like space, a lesion. The inside of the cell looks like a schwannoma. The lesion is often, most always located in the superficial dermis. So that is again another clue. So I'll show you another example of a PEN. It's another example of a palisaded. You can see how the lesion is in the superficial dermis. You can see the nice retraction of the lesion, the cleft-like space from the stroma. And when you go up on high power, you see what looks like a schwannoma. So that is your palisaded encapsulated neuroma. There's another lesion which I'm going to talk about, which is again a benign neural tumor, which is a perineuroma. Okay. Now, perineuroma is one lesion which, if you want to forget, you can forget. It is nice because this is a neural tumor, but it is absolutely negative for neural markers. So all the neural tumors we have talked about till now are going to be positive for S100 and SOX10. Okay. Perineuroma, it is derived from the perineural nerve sheath. Even though it is neural in derivation, it's actually negative for S100 and SOX10. Okay, so that makes it interesting. So this tumor, which most commonly occurs on the extremities, it is a very pink tumor. It's very hypocellular. When you go up on high power, you actually see all these hyalinized bundles. So you may actually think of something like a sclerotic fibroma, right? A storiform collagenoma with those cleft-like spaces. But remember, the storiform collagenoma doesn't have any cellularity. But if you notice in over here, the spindle cells are actually very delicate. You see how they are very delicate with these bipolar cytoplasmic extensions. So to think about a perineuroma is to think about something that looks like a sclerotic fibroma, but it has slightly increased cellularity of the spindle cells, which are very neural looking because they have these very thin, elongated tapering nuclei with these bipolar cytoplasmic extensions. That is your perineuroma. Again, it is a tumor. If you want to forget, you can forget it. It's a pink hyalinized tumor looking like a sclerotic fibroma with proliferation of these very neural looking delicate spindle cells with bipolar cytoplasmic extensions. That is your perineuroma. And this tumor is negative for S100 and SOX10. Okay, let's come to your easy tumor, which we have again already talked about before, which is going to be your granular cell tumor. So we talked about when we did this granulomatous lesions. A classic granular cell tumor will have epithelial hyperplasia, pseudoepitheliomatous hyperplasia. Within the dermis itself is going to be nests on of proliferation of these cells, which have abundant pink eosinophilic granular cytoplasm. You can see the granularity of the cytoplasm and these perinuclear pink inclusions, which are known as the pustulo-ovoid bodies of Millian. So you can see these perinuclear pink inclusions or the pustulo-ovoid bodies of Millian. That's a granular cell tumor. This tumor is neural in derivation, is derived from the Schwannian cells, is S100 positive, and these individual granules are all lysozymes. Okay, so they are all lysozymes. This is a granular cell tumor. This is again a neural tumor in derivation. Okay. The next tumor, which is an important tumor because of the kind of staining questions that they can ask you, is a cellular neurothekioma. So a cellular neurothekioma is a tumor. When you look at it, it actually looks melano. When you look at it, you wonder to yourself, is it melanocytic? Is it neural? If you're stuck between that differentiation, then you're likely dealing with the cellular neurothekioma. So the classic location is actually the head and neck. And these are dermal-based tumors, which are well circumscribed but unencapsulated. And when you go up on high power, they contain these nests of epithelioid cells. So the nest of the cells makes you think it is melanocytic. Okay, but then they have lots of pink cytoplasm. I'm sorry, when you think about something which is melanocytic or fibrohistiocytic, that's when you think about a cellular neurothekioma, not neural. So when you look at the tumor, it's nested, which makes you think about melanocytic, but they have lots of pink cytoplasm, which makes you think it's fibrohistiocytic. That's your cellular neurothekioma. And they the background is this kind of an hyalinized stroma with these epithelioid cells, which look nested, but they have lots of pink cytoplasm. Now, cellular neurothekiomas, they are very interesting because they are going to be negative for your melanocytic markers. They're negative for SOX10, Melan-A, S100. The only S100 they're stained with is S100A. And that's a board question that they like to ask you. So they're S100 and SOX10 and Melan-A negative, but they're S100A positive. They're also stained with MITF. Okay, MITF is again a melanocytic marker, but it's not it does not only stain the melanocytes. So they stain with MITF. And most importantly, they stain with NKI-C3. The other name for NKI-C3 is CD63. So that's the other question that they like to ask you. So they are MITF and NKI-C3 positive. The other name for NKI-C3 is CD63. That's your cellular neurothekioma. So let me show you. This is an example of an MITF positivity in a cellular neurothekioma. So you can see how the nuclei, they stained with this particular marker. That's MITF. Can show you more examples of a cellular neurothekioma. You can see again, it is a well circumscribed lesion. When you go up on high power, you see these nests of epithelioid cells, but they have lots of pink cytoplasm. That's when you think about a cellular neurothekioma. When they are going to show you a cellular neurothekioma, you will know you're dealing with a cellular neurothekioma is because of the kind of question that they will ask you with it. They are not going to make you diagnose cellular neurothekioma, but there is something in the question. So that is why the staining is important. Remember, they are negative for S100 SOX10 Melan-A, positive for S100A, positive for MITF and NKI-C3. The only other name for NKI-C3 is CD63. Okay. Now, don't confuse a cellular neurothekioma with a myxoid neurothekioma. In the past, they were put in the same category, but they're completely different tumors. And the histology of this lesion is not important. This is a very rare entity. The other name of a myxoid neurothekioma is a nerve sheath myxoma. Okay. And they are neural tumors. So they are basically going to be spindle neural cells with lots of myxoid stroma in the background. So it almost looks like a myxoid neurofibroma, but it has differentiating features, which I'm not going to discuss because this is not really important. But don't confuse it with it because myxoid neurothekiomas are S100 and SOX10 positive. Okay, so you have a neurothelioma, which is a cellular neurothelioma, and a myxoid neurothelioma. Cellular neurotheliomas are negative for S100, SOX10, melanin. Myxoid neurotheliomas are positive for S100 and SOX10. Okay, the more important ones let's talk about is going to be the traumatic or your amputation neuroma. So the traumatic or an amputation neuroma is going to be a traumatic proliferation of nerve bundles. So you will see well-formed nerve bundles in a fibromucinous background. So you can see the whole nerve and they are increased in number. So multiple nerve twigs in a fibromucinous background. That's your traumatic or amputation neuroma. This is how like your Morton's neuroma will look like. Okay. Then before I end the neural tumors, the last thing which I'm going to be talking about is if you guys remember, I have showed you this. So this is again a spindle cell tumor, right? It is proliferation of spindle cells in a hyalinized stroma. What is the diagnosis here? What is this pigment in the background? So when you're looking at a pigment in a soft tissue tumor, what are the two tumors that you think about? So first of all, you have to determine what kind of pigment is it. Is it melanin or hemosiderin?
Hemosiderin.
This is non-refractile. It is coarser, darker brown.
So melanin?
It is melanin pigment. Melanin pigment in the background of spindle cells is what? Blue nevus. Okay. And the same pigment, but which is hemosiderin in the background of spindle cells is a dermatofibroma. Okay, so this is important. So this is an example of your blue nevus. This is an example of a sclerotic blue nevus. You see proliferation of the spindle cells in the background of melanin pigment. So whenever they show you a pigmented hypocellular dermatofibroma, or conversely, whenever they show you a sclerotic blue nevus, they will always have a dermatofibroma in the differential. So it is important to recognize what pigment it is. Is it melanin or is it hemosiderin?
How do you like I can't tell if it's refractile or not just by looking at it on
No,
H&E.
so the refractile will shine at you. So let me go back to, I have covered the deposition diseases with you guys, right?
Not yet.
What was the last inflammatory I ended with you all?
We did I can't remember. We're kind of going out of order just because our curriculum is a little bit
Yeah, because that's why I'm also, because you told me to cover soft tissue, but where did we end at inflammatory? I
yeah,
thought I did I thought have I done morphia and stuff with you all?
maybe someone else
No, I
remembers.
have done blue and pink deposition. I have done amyloid and mucinosis and all of that.
I don't think we've done amyloid and mucinosis yet. I think that's going to be a later month, like
I think
maybe.
we did granulomatous. Was that?
Oh yeah,
We
that
did paniculitis.
granulomatous was the last I think we finished the inflammatory disorders though.
Oh no. So so we did spongiotic psoriasiform interface, we did blistering diseases, we did granulomatous, we did vascular diseases,
Mhm.
right?
Yeah, we did vascular.
Did we do paniculitis?
We did.
We did, right?
Mhm.
Then after paniculitis is your blue and pink deposition diseases,
Yeah.
which is your amyloid and myxomas and focal cutaneous mucinosis and digital mucuses. Did we do that?
We haven't done that yet. If you give me like 1 second, I can just look at our academic curriculum to let you know like which month we're doing that. Because
Okay.
give me 1 second.
Because that is the part where we do the blue and the pink deposition, then we do iatrogenic deposition, and that pretty much brings you to the end of inflammatory except infections.
Okay. So I have it that we're doing melanocytic stuff in February, adnexal tumors in April, infections in May. Why don't we do depositional um in March?
Okay, you can tell me what however you want me to go, but that is completely fine. But no problem with that. But so that's why I thought that you guys know, because I talk about this when I do the hemosiderin and melanin pigment. That's there in the iatrogenic deposition. That's when we talk about it. But this is melanin pigment. It is non-refractile, and your the something like hemosiderin would be. I'll have to go back into a DF. Hold on. Something which was a hemorrhagic DF, maybe this one. Let's see. You see, this is hemosiderin. You see how it is refractile? It's shining.
Yeah, it looks more like golden.
Exactly. So this is golden brown. Versus what I showed you is where were we? We were on your stenotic blue levers, which is 160 here. The other one was better. So you see this pigment? It's much more darker brown. It's not refractile. That's melanin.
So
Okay?
you spindle cells plus sclerosis plus melanin is a blue nevus.
Exactly. Exactly. And spindle cells plus sclerosis plus hemosiderin is a DF.
Got it.
Okay. And that's an important question that they like to ask you. The last thing which we will cover also in melanocytic, but you guys should know about, is a desmoplastic melanoma. And the reason is because the desmoplastic melanoma produces proliferation of spindle cells in the dermis, which can look like any soft tissue sarcoma. But the overlying epidermis will show you the melanoma. So here you can see that the overlying epidermis has all this melanoma part of the lesion. So you can see here effacement of the Rete-Rich pattern and this lentiginous junctional proliferation of melanocytes within the lesion. Does everybody notice that? And then in the dermis, you have proliferation of the spindle cells. Sorry. You have the spindle cell tumor. And you see these are the trailing lymphoid aggregates. And all this part of the tumor is going to be positive for melanine. So if you see the melanine, this is the melanocytic marker. It's highlighting only the melanoma in situ. It doesn't say anything in the dermis. So you can miss the desmoplasia if you're not thinking about it. And this is your S100 stain, and it highlights all the invasive melanoma. So you can see all this invasive melanoma in the dermis. So the clue for a desmoplastic melanoma is, if they're asking about you, first of all, it's most often on the sun-damaged skin. You see the melanoma in situ on top. You see the trailing lymphoid aggregates. So these lymphoid aggregates are hiding something in the dermis, and it is all these spindle cells, which is the invasive melanoma. Okay, so desmoplastic melanomas can look like a soft tissue tumor, but it isn't. The last thing is your soft tissue tumor vascular, which we have already done. But so you guys can help me over here. We just finished it when we did all the remember the big study set, but we'll quickly go through everything again. So this is a benign. What is this?
Capillary hemangioma.
This is a hemangioma. Good. So this is a hemangioma. This is another nice example of a capillary hemangioma, right? They look cellular, but you can see that there are some feeder vessels within the lesion. And you see the really monotonous proliferation of these round cells each of which actually is associated with the lumen. So these are all capillary sized vessels. So that's a capillary hemangioma. This is the capillary hemangioma, which can occur in kids. The strawberry nevus or an infantile hemangioma will look like this. And that one is going to be GLUT1 positive. So they can show you these questions and they can ask you questions about syndromic associations. Okay, so this is how an infantile hemangioma will look like. Okay, the next one, you guys will tell me what this is. So well circumscribed vascular tumor. We just studied about it. What is this on the top?
Wait, don't tell them yet. Just like maybe one of the second or first years, because we just talked about this. Just give them like 10 seconds. So this is ulcerated.
That's ulceration. There is no epidermis. This is just serum and crust. And this is the epidermis here. You see, this is the epidermis.
I post a picture of this like once a week.
Versus here, where there is no epidermis. So this is just serum, crust, and inflammation overlying the lesion. And what you see here is the proliferation of vessels. Do you see that? And there is lots of edema within the lesion.
This is a pyogenic granuloma.
This is a pyogenic granuloma. Good. Let me show you an example of, it's a really nice example of, hold on, this is all mixed up. So, so you basically see here, this is all vascular proliferation within the lesion. And these are the big vessels, 3 big vessels, which are then flowering up into these vessels in the lesion. That's a spider angioma. So when they show you this lesion, they will give you some clue about that's what they want you to pick it up. So you can see the well-formed vessels, the feeder vessels, which are giving rise to all these tiny vessels within the lesion, which lack that distinctive wall around them. So that is a spider angioma. So you can see how it proliferates into its tiny spider-like webs. That's a spider angioma. The this one, you guys will tell me what this is. What is that? Ectatic vessels, pink fluid, valvular structures.
A lymphangioma.
That's a lymphangioma. Good job. If the same lesion occurs in the background of epithelial hyperplasia, like this, hold on. So you see the same lesion. Does everybody see the lymphangioma, the dilated vessels, the valvular structure, and the pink fluid, but it's occurring juxtaposed to a hyperplastic epidermis. That's a lymphangioma circumscriptum. Okay. Okay. Now tell me, what is this lesion? It's got some bubble-like spaces. Let's go to another. Okay. So proliferation of vessels which have got these finger-like proliferation with hobnailing endothelial cells. What is that?
Targetoid lymphatic malformation.
Targetoid hemosiderotic hemangioma or hobnail hemangioma. So when they have these hobnailing, finger-like proliferation of these ectatic vessels, if the clinical is targetoid hemosiderotic hemangioma, or hobnail hemangioma, which is the morphologic histologic description. Good job. Okay, what is this an example of? They will give you this high power view. This is again very classic. What are all these in the background? What are these cells in the
Is
background?
this epithelioid hemangioma?
Yep. So you see lymphoid hyperplasia with eosinophilia, and you see these vessels here with the nice hobnailing endothelial cell. So that's angiolymphoid hyperplasia with eosinophilia. This is only high power view you will get, and you'll be able to make the diagnosis because you see the ectatic vessels with the hobnailing endothelial cells and the lymphoid hyperplasia with eosinophilia. Great job. And the other systemic variant of this is Kimura's disease, which occurs in the lymph nodes or in the salivary glands, and those patients have systemic hypereosinophilia and increased serum IgE. Guys, give me 1 minute. Girish, I'm just calling you in like 5 minutes. Bye. Okay. Then the next one, tell me what is this? Oh, this one is let's do another one. So they give you this. What is that?
Give them 10 seconds for this one.
Is this glomus?
Beautiful. Monotonous proliferation of epithelioid cells in association with vessels. So that's either a glomangioma or a glomus tumor. And all of these are smooth muscle actin, SMA positive. Good job. What is this an example of? Show you a much more easier one. Hold on. Okay. There is background hemorrhage and thrombosis. And then what is happening here?
Kaposi sarcoma.
What is that?
Is this Kaposi's?
Nope. It's all in the background of hemorrhage and thrombosis, like a big vein that has undergone thrombosis and hemorrhage. And then canalizing its lesion within its lumen is what?
Oh, it's like the Mason's tumor.
This is Mason's tumor. Let me show you another example. So the background of the lesion is basically very important to recognize that. You see again in here, this is on the acral skin. And this vascular lesion has been taken out. And then you see canalizing its lumen are these micropapillary structures. You see that?
Hmm.
So that is your Mason's tumor. Okay. Now tell me, what is this?
This is like angiokeratoma.
Yep. So then the second order question that they like to ask you with this is the congenital variant, which is the circumscriptum, and not the corpus diffusum, which is in Fabry's disease. It's the angiokeratoma circumscriptum. Yep, that's angiokeratoma. Okay. You guys should know this. This may not be instantly tell me what is this. This may not be a tumor.
Maybe a first year. Give them like 10 seconds.
Hmm.
Look at the arrangement of the vessels. In cannonballs.
This is the stasis.
Yeah, nice.
Stasis dermatitis or acroangiodermatitis. Good job. Okay. Oops. So now you're looking at this is the low power. See all the hemorrhage. What is that?
Maybe another first year. Just give them like 10 seconds though. Spindle cells, hemorrhage, bubble cells.
This is Kaposi.
Nice.
Kaposi. So you see the blister cells with like slit-like spaces and the hemorrhage. Beautiful. That's Kaposi's. Now what is this? So again, you can see a very cellular tumor in the dermis, right? Let me go to the area where I want you to.
So this is like similar to Kaposi's. They still have like a lot of those bubble cells. You have the slit-like spaces, but the cells look more epithelioid
Yep.
with plump nuclei, and they're slightly more atypical.
Mm-hmm. So what is that?
So basically, it looks super similar to Kaposi's. You got the slit-like vessels, and but the cells look more epithelioid. So someone knows this.
Is this AFX?
No, not quite. So think about it. What's the other malignant vascular tumor that is like essentially a death sentence?
Angiosarcoma?
Yeah, this is an angiosarcoma. Let me show you. Ms. Maria was describing it really well. So that was absolutely correct description. This is another example.
So where Kaposi sarcoma has like these like very spindled cells, angiosarc has more epithelioid plump nuclei.
Yes. And it almost looks like, as you said, the slit-like spaces which are randomly dissecting through the dermis, like what you see in here.
Yeah, and this is like nice decapitation where like the cells are like decapitated.
Exactly. They're free floating. Yep.
I think it's easier when you get like a frame of this here, but I think it becomes confusing when you don't have the decapitation.
Okay, so that was great job, guys. I think with that, we have finished the soft tissue tumors. So I will send you a study set, and I think you guys should basically go through that. And then, Maria, when is our next class?
So not this coming Monday, but the Monday after.
You mean to say Wednesday?
Oh, sorry, Wednesday. Yes.
Yeah, okay. Yeah, okay. So what do you want me to do in that Wednesday class?
So let's do like a study set for this.
Okay, we'll do that then.
Okay, perfect. That'll be study set 1 for soft tissue.
What is that?
It'll be study set 1 soft tissue.
Yes. So let me see. I think I will tell Anthony to send you guys that. I hope I have one ready itself.
Because everyone
I do have a soft tissue study set. Yep, I will send you guys this.
Okay, perfect. Cool.
Okay.
So much. We really appreciate your time. I know it's a Saturday, so thank you so much, Dr. Anand.
Thank you. You guys have a good rest of your day.
A couple of the residents were wondering if you could send us that handout.
Yes, I'm going to. You're going to get the access to this and then this one.
Okay, great.
Okay. Thank you. Bye.
Bye.
Thank you.
Bye.
Thank